That's how to set up the vent itself, how to turn the thing on. Now we got to talk about what to do when you run into problems or less than ideal things as you're going along. All right, so let's talk about problems that you might encounter. First, I want to talk about the little bumps in the road. Not the big crashes. This is just a little, oh man, something's a little different. I need to fix it. What do I do with those kind of things? Mostly this is going to be, what if an alarm goes off someplace, either on the monitor or on the vent, or things just look bad. One of the most frequent ones you'll encounter is a low SpO2, a low SAT. On your patient that's ventilated. What are you going to do when you see that? Well, if you remember what I said before, your oxygenation is determined by a combination of PEEP and FiO2. So how much oxygen you're giving plus how much PEEP you have, how many lung segments are open to ventilate. And so when you start thinking about changing one of those, as you would, oxygen, okay, reach over. A lot of us are just going to reach over and dial that FiO2 on up to 100% first thing, or at least a little bit higher, and that's going to be our first move. And usually we forget about PEEP, or we choose not to mess with it. Somebody back there has told us at some point that if you put patients on a lot of PEEP, more than 10, that you're going to explode their lungs and things are going to be terrible, and the inside of your aircraft or the inside of your ambulance is just going to be this big mess, like you slaughtered a hog because you gave this guy a big pneumothorax and then you got a lot of other problems. That actually will not really happen. If you think of the pressure that the ventilator delivers versus the amount of PEEP that you have there, 10, 12 of PEEP, something like that, you're exposing the lungs to a lot more pressure when you give them a breath than when you put them on 12 millimeters of PEEP, because your inspiratory pressure is going to be higher than 12 all the time. So 12 of PEEP, no big deal. It's already a drop in the bucket essentially. Some extra PEEP is not going to hurt the patient's lungs. You won't give them a pneumothorax. There's some other stuff that you can do that you certainly could, but PEEP is not the problem. So we're going to fix his oxygenation. He's at 80%. What are we going to do? We look at our vent table here, we look at our PEEP table here rather, and see that he's on an FiO2 of 40% and a PEEP of 5. And again, his SAT is 80, and I want that to be higher. So my first move, you can use either the upper table or the lower table. They say basically the same thing, but one has higher PEEPs and one has higher FiO2s. You can use whichever one you like, realistically. But say he's on 40% at 5 a PEEP. Instead of bumping up his FiO2, instead of bumping up his FiO2, I am going to bump up his PEEP, and I'm going to go from 5 to 8. And see how he does. And again, I'm going to give that a couple of minutes, a minute or so at least, to equilibrate, let those lung segments open up, let perfusion get back out to his finger there before I make a whole lot of changes, unless he is, again, peri-arrest. We're going to let that sit, marinate for a minute. We come back now, his SAT's 85%. Okay, still a little bit suboptimal for where I want. So now I've gone up on his PEEP. I will increase his FI up to 5. So now he's at 50% FiO2 and 8 of PEEP. I bring these things up at the bottom just to remind you that, again, by the time you get up to 100% FiO2, by the time he's breathing 100% oxygen, your PEEP, if you need it, if that's really the way that things are going, then he needs to have a PEEP of somewhere around 16, 18, 20, 24, 25, something like that. They should be on a lot of PEEP if their FiO2 is 100%. And think about how many times you've seen somebody roll in with on 100% oxygen, but with 5 of PEEP. It just doesn't make a lot of sense. So go up on the PEEP while you are thinking that you need to go up on the oxygen, and print off one of these tables, stick it on top of your ventilator, and use it so that you don't end up in that situation where you're just trying to brute force oxygen into the guy's lungs, because at some point it's probably not going to work. Put 15 of PEEP on the guy and suddenly he oxygenates perfectly, and you can back him back down to 60% maybe. So use PEEP. Don't be scared of it. You're not going to hurt him if you're cautious otherwise, but you're not going to hurt him with PEEP basically. That's oxygenation and a good strategy for it. How about one of the other things we can see, Tidal CO2, CO2 of 18 with a good waveform. So what do we do at that point? Well, you got to kind of keep in mind that Tidal CO2 is a surrogate for the CO2 level, the dissolved CO2 level in the rest of the body that's circulating around. For most of the time, your body's PCO2, the amount of carbon dioxide that's dissolved in your blood, is going to be the same as your end-tidal CO2, relatively speaking, and that's going to be between 35 and 45 in the normal, healthy kind of person. And that's what we're typically going to aim for as our goal on end-tidal CO2 as well, between 35 and 45 for most people that we put on a ventilator. The time when that might be different is for signs of impending herniation after a head injury. So if you think somebody is about to herniate because they've got blown pupil and they're comatose, by the way, you can have anisocoria. The guy who is awake and talking to you and has one pupil that's different than the other is not about to herniate. He may have something else neurologically going on with him, but it's not that he's going to herniate. So if they're comatose and they have a blown pupil, and they're comatose, and they're posturing, then you may mildly hyperventilate them. You may choose to mildly hyperventilate them in order to shrink cause some vasoconstriction in the brain and give you a little bit more space and stave off herniation for a little bit of time, assuming you're being treated appropriately otherwise. And the goal on that one is probably going to be to bump their respiratory rate to about 20, and their end-tidal CO2, in that case, you'll target between 30 and 35. So in most people, we're going to aim for a end-tidal CO2 between 35 and 45. In the folks that have impending herniation that we're trying to decrease their ICP, we're going to target between 30 and 35. And again, that's going to be a respiratory rate, mild hyperventilation, somewhere around 20, maybe 22, something like that. And again, respiratory rate is going to be the thing that we're going to use to change that. Now the question comes up, there's this snake in the grass that's out there. If you try to fix a lot of end-tidal CO2s and go for that normal limit between 35 and 45, there is this thing out there that could potentially bite you. And a big question you have to ask if you are changing somebody's respiratory rate to try to fix an end-tidal CO2, usually because it's too low, but maybe because it's too high, you have to ask yourself, is this normal? And by normal, I mean really, is this a physiologically expected thing? Is this normal body reacting to something else? It may not be normal, like, in terms of what most of the population does, but is this normal for the person? Is this a normal response for the person due to whatever is going on in their body? Lovers, what the hell are you talking about? Well, look at the couple of times when it may be dangerous to try to fix an end-tidal CO2 measurement based on respiratory rate alone. Again, a brief primer on blood gases and how everything pH homeostasis in the body. Just remember that it's a combination of the lungs and the kidney. The lungs fix things fast, the kidneys fix things slow. The thing that we can really change over a short period of time is the lungs. And if you leave them that way for a while, then the kidney eventually catches up over a couple of days. But changes that happen to your CO2 happen in the lungs relatively quickly, and we don't have a good way to immediately sort of fix any problems that may come up with changes in our CO2. Your acid-base status, your blood pH is going to either fall or rise, largely in the acute setting based on what your lungs are doing. So let's say that you have this. We've intubated a patient for whatever reason. He's a trauma patient, let's say. Got the tube, have a good waveform down at the bottom. The tube is definitely in the right spot. He's breathing about 30 times a minute. Spontaneously, we'll say the sucks is worn off. And we find an end-tidal CO2 of 11. You may say, well, that number's really low, and that doesn't seem right, so we should probably try to fix that. And so you may give him, more sedative, or if he's on a vent at that rate, then you may turn that thing down. And the problem with that, or you may turn the respiratory rate down from 20, you try to turn it down to 10, and you give him a big slug of propofol so he stops breathing spontaneously. The problem with it is that you don't know if the guy's blood gas looked like this or like this. So on the one side, on the left-hand side, the guy is alkalotic because we're hyperventilating him. And that could be, again, because he's anxious or because he's in pain or something like that. But in this case, he's got a normal bicarb, normal lactate. He wouldn't be acidotic otherwise. And the reason that his CO2 is low is because we're doing something. We have the ventilator set too high or something like that. Or he's breathing too fast because he's anxious or in pain. that's that case. And in that case, if you were to fix his end-tidal CO2, okay, that would be probably reasonable. The problem is that you don't know that he is not case number 2 here, where his pH is already low. His CO2 is low because his body is fighting like hell to try to blow off as much acid, as much CO2 as possible to get his pH back up or keep it at least where it's at. In this case, this guy has a terrible metabolic acidosis and a low pH already. And if you put him on a respiratory rate of 12, trying to fix that end-tidal and get it up to 35, the next thing that you'll be doing is chest compressions and defibrillation. This guy will probably die as a result of it. So you can't do that, and this does happen all the time. The patient with a metabolic acidosis that has a low CO2 may be just really, really compensating for that metabolic acidosis, and fixing it puts you and the patient potentially in peril. So if you're going to try to fix a low end-tidal CO2, then do so with caution and try to make sure that you at least have a blood gas so that you know what the heck is going on with the patient's acid-base status otherwise, because all you'll have on the ventilator and the monitor is one piece of the puzzle, and there are 2 more pieces, namely the patient's bicarbonate and the patient's pH, that are critically important to know before you go monkeying around a lot with that. So be warned, be cautious if you're going to fix a low end-tidal CO2 in most of these patients. The other time when this might become a problem, which I'll just hit on briefly, is if you have a COPD patient that is hypercapnic, meaning they have a CO2 of 110 or something like that. The thing is that patient may be used to living at a CO2 of 110, or at least at 70. They may have compensated for that. Their bicarbonate may be, 60 instead of 25. They may have had enough time over the course of their terrible lung disease to get that fixed for their body to become used to that. And if you try to fix it, if you try to blow off that CO2 and try to get it down to a quote-unquote normal value at 45, then not only are you really going to be working the ventilator pretty hard and potentially causing a lot of problems for the patient, it doesn't need to be there because the patient's used to hanging out at a CO2 of 70 or 80. So in that case, you can hurt the patient by trying to make them better just from the physical stress on their lungs, from the likelihood that you're going to have to increase the respiratory rate and potentially cause more barotrauma, potentially cause breath stacking in these COPD guys, and really hurt them in that way. So you do have to use some caution if you are going to try to fix their end-tidal measurement based on their respiratory rate. That said, give them a couple of minutes once you get the person on the ventilator or get the person intubated to see what their CO2 actually comes down to. If they've had a long apneic period, their CO2 may be 60 or 70. But if you leave them on just reasonable vent settings for a couple of minutes, they likely will blow that back down and come back down to a normal level. So once you put somebody on the vent or once you make a change, give them a couple of minutes to equilibrate, and then we can see what happens. So, just to summarize all that, to pull it all together, one might say, don't forget that the patient is about 50% of the ventilator circuit. And if you're going to do the whole vent thing, then you have to remember that the patient is part of that setup. So make sure the patient is at least comfortably sedated, you know their physiology, you know something about them, and have a backup plan for how you're going to keep them asleep during transport, because you don't want the Hulk waking up and smashing up the back of your ambulance after he extubates himself. Remember that your SpO2 never should be 100% if you can help it. So between 94 and 99, there's no benefit to getting it from 99 to 100. There's definitely harm that can happen for a lot of diseases when you do that, and you don't need it that high. So if his SpO2 is 100%, do something to fix that so that it's not 100%. 98, 99 is just fine. We're going to put end-tidal CO2 on every tube and everything we stick in somebody's mouth and everything we put over somebody's face. We're going to do that every time. And the tube is not in the right spot until you see a relatively normal appearing end-tidal CO2 waveform. And if you don't have the ability to see an end-tidal CO2 waveform, you probably shouldn't be doing any kind of airway management in my mind. There's no reason not to at this point. For most patients, head injury patients, vomiting patients, aspiration patients, pneumonia patients, CHF patients, we are going to use a strategy of a low tidal volume, a relatively high rate to maintain a normal CO2, and a relatively high PEEP on these folks to avoid damaging their lungs. Folks with obstructive lung diseases like asthma and COPD are different. We're going to use a relatively low-ish tidal volume. We're going to slow that rate way down, and if that means their CO2 goes up, that's okay. That's fine. They'll tolerate it as long as we can oxygenate them reasonably. And we're going to use a relatively low PEEP in these guys. So slow rate, long I to E ratio in order to let the patient breathe out so that we can get air back in. Remember that oxygenation is primarily driven by PEEP and a little bit by FiO2. If you got to pick one or the other, choose PEEP to change first. And then it is okay to fix a high end-tidal CO2, generally speaking, especially in folks that don't have obstructive lung disease. It's generally speaking safe to fix a relatively high end-tidal CO2. If the patient has a low end-tidal CO2, you have to be very cautious when you fix it, because if that patient's in shock or is acidotic or has bad DKA or whatever their individual pH problem may be, if you try to fix a low end-tidal CO2, you may kill the patient when you do so. So use caution with that. And that's ventilators, or at least most of what I know about ventilators. This can be a complex topic, and certainly this is not meant to take over for any of your local protocols. And again, remember that your ventilator is your ventilator, and you got to know what it does and what its limitations are and what the individual settings mean for that ventilator. So get to know it, get the thing out, hook it up, and try to actually use the thing a little bit more. You're never going to be comfortable with it until you get your hands on it a bunch. So that said, send us an email if you have any questions, emsgrandarounds@gmail.com, and we'll talk to you next time. Thanks.